recording, please. Assalamu alaikum. My name is Kiran Amir and I'm the Director Operations at PARSA ECHO Pakistan Super Hub. I would like to welcome you all to the new ECHO session in series of Hepatitis ECHO. It's in collaboration with Pakistan Society of Hepatology. Please try to join the session through the iECHO email link to mark your attendance. We also like to thank Ferozzon's Laboratories Private Limited for their unrestricted educational grant. Before I introduce you to our expert for tonight's session, we have to go through some standard announcements. We are part of a global movement called Project ECHO based in USA, intending to disseminate knowledge and best practices. PARSA ECHO Pakistan started as hub in 2017 and became the first super hub in Pakistan in 2021. We are following the guidelines of Project ECHO with an objective that community providers learn through video technology to participate in guided practice with specialist mentors. They acquire new skills that allow them to treat patient otherwise referred out. Patients with chronic condition get high quality care without travel and waiting. We protect patient privacy, so no information in this session will identify any individual or patient. For maintaining discipline, you all are muted, but we do encourage participation. So you can unmute yourself for question or use the raised hand option or chat box. By participating, you have given the consent for recording. The recorded session will be available on request. For CME credits, please get in touch with Uzair. CME credits are affiliated with Jinnah Sindh Medical University. Uzair will share the Google form at the end of the session, which will be active for 24 hours. You are requested to fill it as soon as possible to avail the opportunity of CMEs. For the convenience of participants, the session is bilingual. Please speak in Urdu or English, whatever language you are comfortable in. Our expert for today's session is Professor retired Altaf Alam, is former professor and head of gastroenterology hepatology department at Sheikh Zayed Graduate Medical Institute, Sheikh Khalifa bin Zayed Al Nahyan Medical and Dental College, Lahore, Pakistan. He is trained gastroenterologist with more than 20 years of experience in his specialty and is the author of more than 50 publications. He is serving as course director at PARSA ECHO Pakistan since the beginning. He is responsible for developing curriculum, observing quality of content, and evaluating speakers and feedback evaluation. So I will now hand over to Professor Altaf Sahab.
Thank you, Kiran. I hope you can hear me.
Yes, we can.
Okay. So let me share my screen. Okay. So Kiran, can you see the slides now?
Perfectly.
Okay. Thank you very much. So let's start. The topic for tonight is whom and how to treat in chronic hepatitis B. And I have added this component, when to stop treatment as well. So, you should know when to stop once you have started a treatment. So it's an important addition that I have made myself. I have no disclosures to make, and I bring greetings from my hometown, Lahore, Pakistan, with this beautiful picture of Lahore Fort. Now, whom to start HBV therapy? Unlike hepatitis C, where you don't ask this question because everyone with viremia has to be treated. But so far, according to the guidelines, we do not treat everyone with chronic hepatitis B. And this has been discussed in detail in the last session by Dr. Javed Iqbal Farooqi about the 4 phases of chronic hepatitis B and whom to observe and whom to consider for treatment. This has also been discussed that you need certain investigations, but I would repeat them because it is important that you should have CBC, INR, creatinine, sodium, sugar. This way you will detect many diabetics. LFTs and albumin, of course, alpha fetoprotein in appropriate setting. not in everyone. For example, in a 20-year-old with a non-cirrhotic liver, you don't need that. But you certainly need uh, all these viral studies: hepatitis B surface antigen, E antigen, anti-HBe, anti-HDV, Delta virus, anti-HCV, HIV, because the transmission is through the same route, and HBV DNA by PCR quantitative. These are mandatory because, as you will see, based on the guidelines, you need to have these data in hand before you consider treatment. Of course, ultrasound abdomen and non-invasive methods of fibrosis scoring like APRI and FIB4 should be always calculated. And if you have the option of fibroscan or shear wave elastography, that will add further to the knowledge that you want to have about this particular patient. Liver biopsy is hardly ever done these days, whereas TSH, fasting lipids, and HbA1c are not mandatory, but you can do them in appropriate setting, or if the patient can afford all these tests, because uh, many of these things will be detected. Hyperlipidemia, hypothyroidism, and diabetes will be detected by doing these tests. This has been discussed in detail last time about immune tolerant, immune active, both e antigen positive and negative, and inactive carrier state. And the numbers or the viral load and the ALT are given here again. Just for the revision, immune tolerant phase is when the viral load is very, very high, and the sorry. When the viral load is very, very high, typically more than 1 million with normal ALT. And if you do liver histology, you won't find any damage in the liver. Immune active may be E antigen positive or E antigen negative. If more than 20,000 with raised ALT, it is associated with inflammation and fibrosis, is an indication for treatment. E antigen negative, more than 2,000 raised ALT with necroinflammation and fibrosis, is an indication for treatment. Inactive carrier state, where ALT is normal, viral load is less than 2,000 international units, E antigen is negative, and if you happen to do a liver biopsy, there is no inflammation uh, or necrosis or fibrosis. EASL has changed the terminology, and they call immune tolerant phase is chronic hepatitis B infection, whereas immune reactive, which is E antigen positive, where the ALT is elevated, as chronic E antigen positive hepatitis. Whereas inactive carrier state is the E antigen negative inactive carrier state is called chronic infection, whereas E antigen negative with raised ALT and raised viral load is called E antigen negative chronic hepatitis. And these highlighted red circles indicate that these are the two definite indications for treatment. And as Dr. Faruqi was saying last time, that in other phases, you could treat as well in certain situations, not in all. These are the EASL clinical practice guidelines. Whether you are E antigen negative or positive, viral load is more than 2,000, and ALT is more than upper limit of normal, with at least moderate liver necroinflammation or fibrosis, these patients should be treated. Cirrhosis if you have either compensated or decompensated cirrhosis, they always need treatment provided there is detectable HBV DNA, whatever the ALT levels and whatever the HBV DNA levels. So the virus should be positive and then you treat. If the viral load is more than 20,000, ALT more than upper limit of normal, then you don't need any fibrosis or necroinflammation scores, you treat straight away. These two new indications have been added for the last 6 years or so. E antigen positive chronic infection who are more than 30 years old. This is immune tolerant people who are more than 30 years old. They have persistently normal ALT, very high HBV DNA, and they may be treated if they are more than 30 years, regardless of the severity of liver histological lesions, regardless of the ALT. So age matters, and I'll tell you later why. The other category that has been added in the last EASL guidelines is E antigen positive or negative, 2,000 and more than 20,000, but they have a family history of HCC or cirrhosis, and extrahepatic manifestations should be treated even if typical treatment indications are not fulfilled. Just the other day, I had a patient who had a viral load of only 400 international units. ALT was normal, but his father died of hepatocellular carcinoma, so I started him on treatment. There are certain other exceptions which I'll discuss in the subsequent slides. Now, the question is, according to the EASL guidelines, if you have a viral load of more than 2,000, ALT is more than upper limit of normal, it states that there should be significant fibrosis and inflammation. And what is this significant fibrosis and inflammation? Significant fibrosis is F2 or higher. So equal to F2 or F3 or F4. So this is fibrosis. This can be determined by liver biopsy, by fibroscan, shear wave elastography, or by non-invasive tests like EPRI and FIB4. Necroinflammatory activity, unfortunately, is usually determined by liver biopsy. There is no other test for that. And a score of 2 or higher signifies significant inflammatory activity. Just to highlight that AASLD in 2018 has reset the normal values of ALT for men as 35 and for women as 25. But rest of the world does not agree with that. Europe, UK, and the rest of the world still follows that upper limit of 40 or 45 based on their own lab upper limits. So this is only for US, that men 35, women 25. Now, recently, just the end of last year, Chinese hepatitis B guidelines have come out. They are a little bit different from the American and the European guidelines. And what do they tell you? Surface antigen positive. You have to look for liver cirrhosis, liver failure, HCC, whether the patient has had liver transplant, whether the patient is receiving chemotherapy or immunotherapies or immunosuppressants, and or DAA treatment for HCV, because this will matter. If you have a patient with HCV and HBsAg is positive, maybe DNA is negative, and you want to start DAAs, you need to treat for B, because risk of activation of hepatitis B is very high. And in these situations, you start nucleotide analogs, follow up every 3 to 6 months. So this is in a surface antigen positive person. If a surface antigen positive person is HBV DNA detected or positive, and ALT is more than upper limit of normal. Remember, they do not signify any levels. They do not say 2000, they do not say 20,000, they say detected. And ALT, upper limit of normal, there is no other cause of liver disease or the cause of ALT elevation, you start treatment. If the ALT in a detected HBV DNA positive patient, ALT is normal or less than normal, you only treat if there is a family history of HBV related cirrhosis or HCC. Age is more than 30 years old. This is in line with EASL guidelines. And or histological, non-invasive or histological examination indicates significant fibrosis or inflammation. Uh, Again, more than 2 for both, equal to or more than 2 for inflammation and fibrosis. Or there are HBV extrahepatic manifestations. And of course, if there are none of these conditions, you do not treat and you follow up every 12 months. If in a surface antigen positive patient, DNA is negative, you just follow up every 6 to 12 months. Now, Chinese also treat patients with cirrhosis in whom there is no other cause of liver disease, but DNA is negative and surface antigen is positive. They also treat for, but only in cirrhosis. They treat them. These are very good guidelines and a little bit different from the rest of the world. So I would encourage you to read these few pages. They are very simple and they highlight that we are progressing towards a direction where we probably would be treating all viremic patient, whatever the number, whatever the ALT in future. So we are moving in that direction, and the Chinese guidelines are just the first step in that direction. Now, we also treat some people outside the guidelines. And what are these conditions? Healthcare workers. An orthopedic surgeon working in UK has a viral load of 500 HBV DNA of 500 international units per mil. Whatever the ALT, he will not be allowed to work as an orthopedic surgeon, or as we call it, exposure prone procedures. Somebody who is doing exposure prone procedures, they will not be allowed unless the viral load falls to 200 international units or less by treatment. So these are exceptions. Pregnancy, ALT normal, liver normal, but viral load more than 200,000 international units, you would treat in the third trimester to prevent vertical transmission. Not to treat the mother, but just to prevent vertical transmission, and you can stop treatment after 12 weeks. The baby can be breastfed. Patients on chemo and immunosuppressive agents, they need to be treated because otherwise there will be reactivation or activation of the virus if they are only surface antigen positive and DNA negative. For certain agents like rituximab, anti-CD20 antibodies, if you are using that, even if surface antigen is negative and anti-HB core is positive, you would treat preemptively to prevent reactivation of the virus. High hepatitis B surface antigen quantitative, this is something new. It's not the same as surface antigen. It is done by a different method, by Roche Alexis or Abbott Architect method. And if you have high quantitative surface antigen, you would consider treatment. Same is true for hepatitis B core-related antigen and HBV RNA. These are new markers to help you in starting treatment or stopping treatment or assessing the progress of the disease. And I'll tell you later that these are all the markers of cccDNA or integrated viral DNA in the host genome, uh, which defines, which can be detected by these tests. Co-infections with HCV, HDV, and HIV, here you need treatment. Of course, there are going to be separate sessions on most of these, and you will, uh, uh, you know, listen to the details of each and every aspect. Old age, I always consider I have a low threshold for treatment in older age, and the guidelines already tell you that more than 30 years, whether the patient is immune tolerant, you consider treatment. And of course, severe acute HBV, defined as prolonged acute HBV lasting for more than 4 to 6 weeks, along with coagulopathy, high bilirubin, and progressing or already developing hepatic encephalopathy, you will consider treatment, although you don't normally treat acute hepatitis B in general. Now, what is the assessment needed? These has been discussed, but I will tell you once again that surface antigen, E antigen, anti-HBe, and HBV DNA are the important viral markers which should be done in every patient. Biochemical profile, especially ALT, fibrosis markers, either by non-invasive or by elastography or liver biopsy, should be done as appropriate. Always screen for HDV in surface antigen positive patients. This is something that we all miss. Even in the Western countries, this is missed. So it is important that you do that. Otherwise, you will miss out on many cases who have co-infection with Delta, and you will not be able to, know unless you check for that. The goals of HBV therapy are to reduce the viral load, improve liver histology, improve biochemistry, especially ALT, and if appropriate, like E antigen positive, you get seroconversion from E antigen positive to anti-HBe positive. Although the final goal is surface antigen loss, but we hardly ever get it. And if you are able to achieve these goals, you can prevent cirrhosis, HCC, and death. But unfortunately, unlike C, for many patients with hepatitis B, you need lifelong therapy to achieve these goals. Dr. Faruqi last time mentioned about Reveal HPV. It was basically a follow-up of a cohort of patients with hepatitis B for a long period of time. So we have some useful information, although this is more than 20 years old, but it gives you very useful information. It tells you that the cumulative incidence of cirrhosis increases with viral load. So if it is more than 1 million, there is, over a period of 13 years follow-up, 36% chance of liver cirrhosis. So viral load matters. Cumulative incidence of HCC is also related to viral load. And whether you are E antigen positive or E antigen negative, higher the viral load, higher the incidence of HCC over a long period of follow-up. What about the disease progression with persistently normal ALT at study entry? If you are E antigen positive and DNA more than 2,000 copies, 2,000 international units. I have converted this into international units. 2,000 international units, there is high chance of progression of disease. Same for E antigen negative and viral load of more than 2,000 international units per mil. But look at that. E antigen negative, viral load less than 2,000 with persistently normal ALT, the disease progression is not zero. It is low, but it is still in the red. So that is why all these things matter. Viral load matters for cirrhosis and HCC and ALT. Uh, Even with normal ALT, there is risk of disease progression. So that is why there is now a tendency towards treating all patients with DNA positive and even with marginal ALT elevation, like the Chinese guidelines I have mentioned. What drugs to use? Very simple now, 3 oral drugs and pegylated interferon, which is still there. Entecavir, tenofovir alafenamide, and tenofovir disoproxil fumarate. They are all high potency with high genetic barrier to resistance. PEG interferon is less safe with cirrhosis and certainly contraindicated with decompensated cirrhosis. So you have 3 oral and 1 injectable drug. The doses, and remember, you need to reduce dose according to creatinine clearance, as mentioned here. Simple way is to more than 50, no reduction across the board. Between 30 and 49, alternate day treatment, 0.5 milligram every 48 hours. 10 to 29, every third day. Less than 10, 0.5 milligram per week. And the same applies for TDF. TAF is different. It is it is given in the same dose. The dose is not reduced as long as the creatinine clearance is up to 15 mil per minute. So no reduction till 15. And now it is recommended between 15 and hemodialysis. There is no recommendation, but on hemodialysis, you can use that again. Now it is recommended to be used for hemodialysis patient. What are the advantages of when to use TAF and not TDF? If the person you are treating is more than 60, he has bone disease of any type or renal disorders of any type, you should use TAF rather than TDF. So far, TAF is not recommended or not approved for use in children, pregnancy, or in decompensated cirrhosis. But evidence is coming up, and there is multiple data in literature for use in pregnancy and in decompensated cirrhosis, where it is equally effective with no bad effects. How to manage persistent low-level viremia, which is less than 2,000 by definition. After 2 years of treatment, the message is very loud and clear: continue with the same drugs. There is no point in adding drug at this stage. There is no data to support that. There is an app on your smartphone which you can download called Hep B Consult. It gives you an option to follow any guidelines. You can select EASL, you can select ASLD, you can select APASL, and enter the patient data. E antigen, here I've entered the data: E antigen positive, DNA more than 20,000, ALT normal, liver histology or fibrosis normal, and it tells me monitor, do not treat. So if you are having difficulty, then you can choose the type of guideline that you want to use and enter your patient's data, and it will tell you what to do. It is called Hep B Consult, and it is available in your smartphone. You can download from the Play Store or an iPhone, and then use it for your patient management if needed and if you are not confident in a particular situation. There is another important question: when to stop therapy. This is unlike hepatitis C, where there is a standard 3 months of therapy, even less in certain situations, even 8 weeks. In non-cirrhotics, if you are using glycaprevir in combination with pabradasvir. So when to stop HBV therapy? There have been optimal endpoints. For e antigen positive, there should be e antigen loss and seroconversion. That is, e antigen should become negative and anti-HBE should become positive. There should be HBV DNA suppression, but that is the question: to what level? And generally speaking, it should be negative at the time of considering stopping therapy. The ideal goal is surface antigen loss and appearance of antibodies to HBS, but this hardly ever occurs with oral nucleotide or nucleoside therapy. It does occur with greater frequency with pegylated interferon in the range of 8 to 15% after 5-year follow-up. For many of these endpoints, they are never reached. So indefinite therapy may be required whether you are e antigen positive or negative. But if you have a patient with advanced fibrosis, which is F3, and cirrhosis, which is F4, do not stop treatment, whether e antigen positive or e antigen negative. So upfront, you need to tell the patient there are certain endpoints of stopping therapy, but in majority, vast majority, they are never reached and you have to continue therapy long term. For e antigen positive who seroconvert to anti-HBE or nucleotide therapy, the guidelines say that you can consider any discontinuation if your patient is not cirrhotic. Once again, I'll repeat, not cirrhotic. In cirrhotic, you will never consider stopping treatment. So following a treatment consolidation period, which should be more than 12 months. The Chinese guidelines tell you that it should be certainly more than 18 months and preferably up to 3 years. Or the alternative approach is to treat until surface antigen loss or long term. Across the guidelines, length of consolidation therapy varies. EASL and ASLD at least 12 months, a PARSA at least 12 months, preferably 3 years. So as I mentioned in the Chinese guidelines. So what is happening? You start treatment, DNA becomes negative, ALT becomes normal, hepatitis B E antigen becomes negative, anti-HBE becomes positive. From this point, you continue treatment preferably for 3 more years and only then consider stopping treatment. These results are irrelevant because with oral treatment, you hardly ever treat for 1 year. But as you can see, the seroconversion does not occur across the board. It is hardly seen in 20% of patients, whatever drugs you use. And surface antigen loss is minimal. In 1 year, 2 to 7 with PEG interferon, at 4 to 5 years, 4 to 5% in 3 years with oral drugs. So this is hardly ever seen surface antigen with the currently used oral drugs. Now, the relapses occur if the duration of consolidation is lower, not seen, and there is maintained response in more than 2/3 of the patients. If you decrease the consolidation period, the response rate also falls, and these patients relapse when you stop treatment. Here again, age matters. If you have an older gentleman with less period of consolidation, the recurrence is very high. But if you have a young patient with prolonged consolidation period, the relapse is less when you stop therapy in E antigen positive disease after seroconversion. So in E antigen positive chronic hepatitis B, in those with advanced fibrosis and cirrhosis, treat indefinitely unless a strong rationale for treatment discontinuation exists. Otherwise, at the time of seroconversion to anti-HBe, if less than 40 years, can consider stopping after more than 12 months of consolidation therapy, preferably 3 years. If more than 40, you can individualize the decision to stop. I generally do not stop in such patients because they have higher chance of relapse, as I've shown in previous slide. Of course, treating up to surface antigen loss may be preferred, and you can decide not to stop therapy and continue until this endpoint is achieved, which hardly ever occurs in oral therapy. If you stop NA therapy after 3 years of consolidation in an E antigen positive patient, please monitor for recurrence of or relapse of viremia, ALT flares, seroreversion, and decompensation every 3 months for at least 12 months. So these patients, if you stop therapy, require very close follow-up. What is the situation of stopping therapy for E antigen negative? If no cirrhosis, the best thing is to treat indefinitely. Of course, in cirrhosis, you will treat indefinitely, unless there is a compelling rationale for treatment discontinuation. There is a lot of variability in various guidelines. EASL tells you if no cirrhosis, at least 3 years of viral suppression on treatment, and the capacity for close monitoring after stopping treatment, you can stop. So yahan par, our patients don't follow up. So it is very risky to stop in E antigen negative disease. So I prefer never to stop and continue. Easy way out. A parcel tells you that if no cirrhosis and at least 2 years of treatment with undetectable HBV DNA had 3 separate visits 6 months apart, that is 1.5 years, or if compensated cirrhosis, with a careful monitoring plan, you can stop therapy. I do not agree with compensated cirrhosis, and I do not stop treatment ever in cirrhosis. In E antigen negative, the responses are fairly similar. Suppression, very high, and here we are not talking about E antigen seroconversion because this is E antigen negative. So this is very high. But as you can see, the surface antigen loss with oral therapy is almost zero. This is different from E antigen positive, where you are getting at least some loss after 3 to 5 years of treatment. Here it is zero. So that is why in E antigen negative disease, treatment is lifelong. I'll skip that. So in summary, if you have an E antigen negative non-cirrhotic patient with advanced fibrosis or cirrhosis, treat indefinitely. Otherwise, treat until surface antigen loss, which is preferable. And this will not be achieved with nucleotide analogs alone. NA withdrawal strategies appear promising, but premature to recommend as standard of care. So, this is a difficult area. What my advice is, continue treatment lifelong. What is the definition of cure in chronic hepatitis B? It is not like hepatitis C. This is what we are getting now. A patient is 3 years of treatment, HBV DNA is lowered or not detected, E antigen is negative, surface antigen is positive, cccDNA is detected if you use liver biopsy and quantitative check of cccDNA, and integrated HBV DNA is detected. These are the two viral DNAs which become a part of the host genome and they never leave the host, and that is why relapses occur. And it was discussed by Dr. Javed Iqbal Faruqi. Of course, our aim is functional cure or complete cure. In functional cure, DNA is not detected. E antigen becomes negative if it was positive. Surface antigen becomes negative with or without anti HPS. CCC DNA is still detected, but it is not active. But integrated HBV DNA is detected. Whereas in complete cure or sterile cure, HBV DNA, E antigen, surface antigen, all are lost. But in addition, CCC DNA is not detected, and integrated HBV DNA is not detected. By the way, this is only detected by doing liver biopsy and quantification of integrated or CCC DNA. But there are indirect markers, as I mentioned, quantitative surface antigen, hepatitis B core-related antigen, and also HBV RNA, which we don't have, but we have surface antigen quantitative in our labs. So now it should be fairly simple. A 32-year-old male, surface antigen positive, E antigen positive, anti-HBe negative, C negative, delta negative, HBV DNA 40,000. During 6 months of follow-up, his ALT remains elevated at 102. Creatinine, ultrasound, APRI, all normal. No previous history of treatment for hepatitis B. What will we do? According to the current guidelines, we will treat. So you can choose entecavir, you can choose TDF, but TAF should be may or may not be used. He's not 65, does not have any bone or kidney disease. So, you may or may not use. Pegylated interferon is also an option here because he's not a cirrhotic. A 52-year-old male, surface antigen positive, E antigen negative, anti-HBe positive, CD negative, DNA 62,000, and his ALT remains elevated at 100. Creatinine, ultrasound, APRI, all normal. Treatment naive. What will we do? Simple. Treat. Viral load more than 2,000, ALT elevated. Treat. You have a 55-year-old female, surface antigen positive, E antigen positive, anti-HBe negative, ALT 44. According to my lab, it is normal. DNA 1900 international units, not reaching the so-called 2000 level. But look at these. Ultrasound shows cirrhotic liver with splenomegaly and mild ascites. So this is decompensated cirrhosis. PEG interferon is not an option here. And as the viral DNA is positive, whatever the ALT, it should only be positive. You will treat and continue treatment lifelong. So that is an important message in cirrhotic, whether E antigen positive or negative, continue treatment lifelong. But before you embark on treatment, please talk to your patient about the natural history of the disease, lifestyle modifications if needed. There is a father with 5 children at home. He has a wife. So you need to talk about family vaccination. I have written here. And until the wife is fully vaccinated with 3 doses and seroconversion of anti-HBs documented, they need to have protected sexual intercourse. So it is important to talk about these. Protection from hepatitis E and A, for that matter, by clean food, clean water, and vaccinating for hepatitis E in those countries where it is available. Don't forget vaccination for flu, pneumonia, and COVID-19. You must talk about drugs, hepatotoxic drugs and alcohol. You must talk about the diet in a normal person with no decompensated cirrhosis. Normal diet has to be taken, and family vaccination has already been discussed. So it is important to talk to your patient before you embark on your treatment. So what are the key take-home points? Never stop HBV treatment in patient with cirrhosis. E antigen positive at treatment start, use E antigen seroconversion to guide decision on stop. At least 12 months of consolidation period, but my recommendation is follow 3 years rule. And they also tell you preferably 3 years. E antigen negative at the start of popping, ensure prolonged period of HBV DNA undetectability and normal ALT prior to stop, at least 3 years. And be prepared to monitor very, very closely. What does that mean? Every month for first 6 months. And what do? You do HBV DNA, you do LFTs, you do ultrasound, etc., etc. So you know it's very costly affair, and you should manage HBV flares by restarting treatment immediately if it occurs. So I stop here. Thank you very much for your patient listening. And this brings me to the end of my presentation, and I will be happy to take any questions, comments, or any suggestions if there are any. Thank you.
Thank you very much, sir, for a wonderful talk. पार्टिसिपेंट से सिर्फ यही कहना चाहूंगा, ये हेपेटाइटिस सी जो है, हेपेटाइटिस बी सॉरी, इट्स प्रीटी कॉम्प्लिकेटेड, और आप लोगों को बार बार इन चीज़ों को देखना पड़ेगा, whom to treat और whom to observe. लेकिन जैसा कि अल्ताफ साहब ने कहा, पहले फारूकी साहब ने भी बात की थी, जो ट्रेंड है दैट इज नाउ मोर एंड मोर टुवर्ड्स ट्रीटमेंट. क्वेश्चंस जो हैं, ये चैट में क्वेश्चन है, इन HCC इन हेपेटोसेलुलर कार्सिनोमा एट विच स्टेज टेस्ट शुड बी परफॉर्म एंड प्रोग्नोसिस. ये क्वेश्चन जो है इससे रिलेटेड नहीं है. ब्रीफली मैं इतना ही कहूंगा कि ये जितने डिसीजंस होते हैं लिवर कैंसर की ट्रीटमेंट में, यूजुअली दे आर टेकन इन मल्टी डिसिप्लिनरी टीम सेटिंग, जिसमें हेपेटोलॉजिस्ट, इंटरवेंशनल रेडियोलॉजिस्ट, ऑन्कोलॉजिस्ट, लिवर ट्रांसप्लांट सर्जन बैठते हैं, और उस पे ही ये प्लान डिस्कस होता है. तो इससे ज्यादा तो मैं इस पे कोई और कमेंट जो है वो नहीं करूंगा.
छोटा सा जवाब दे देता हूं कि MDT की सेटिंग में अगर पेशेंट का लिवर अच्छा है, परफॉर्मेंस स्टेटस अच्छा है, और वो किसी क्यूरेटिव ट्रीटमेंट के लिए सूटेबल नहीं है, रिसेक्शन, ट्रांसप्लांट, वायरल ट्यूमर लोड ज्यादा है और उसकी आप माइक्रोवेव या रेडियो फ्रीक्वेंसी अब्लेशन नहीं कर सकते, तो ये पैलिएटिव ट्रीटमेंट के तौर पे आप टेस्ट करेंगे with a palliative intent. Of course, in some patients it has very good results, but palliative intent to improve the prognosis of the patient from 6 months to more than 1 to 2 years. So that is the aim. Thank you.
Thank you. Any question from the audience? अगर आप इस presentation से related आप कोई question करना चाहते हैं तो. डॉक्टर अल्ताफ, अभी आपने जिक्र किया था प्रेगनेंसी में, और प्रेगनेंसी में मसलन इन अ प्रेग्नेंट लेडी जो है उसमें हेपेटाइटिस बी सरफेस एंटीजन पॉजिटिव है, अगर हम लोग डीएनए कट ऑफ की बात करते हैं 200,000 यूनिट्स पे, और आई एम टॉकिंग अबाउट टू रिड्यूस द चांसेस ऑफ ट्रांसमिशन टू द न्यू बॉर्न, तो ये कितना रिजिड है, और आप प्रैक्टिस में क्या करते हैं? यूजुअली अगर डीएनए डिटेक्टेड हो, एएलटी वगैरह नॉर्मल हो, तो वुड यू स्टिल कंसीडर ट्रीटमेंट टू प्रिवेंट ट्रांसमिशन, और प्रैक्टिकली आप क्या करते हैं?
मैं तो इस गाइडलाइन को फॉलो करता हूँ. उसकी वजह यह है कि दिस केम फ्रॉम अ वेरी एलिगेंट स्टडी, जहां पर अगर वायरल लोड लेस देन 200,000 इंटरनेशनल यूनिट से कम हो तो ट्रांसमिशन का रेट is less than 1%. So आपने क्या अचीव करना है. बट एक सिचुएशन सिर्फ है कि डिस्पाइट लो वायरल लोड लेस देन 200,000 इंटरनेशनल यूनिट्स पिछले बच्चे को पिछली प्रेगनेंसी में ट्रांसमिट हो गया था डिस्पाइट एक्टिव एंड पैसिव वैक्सीनेशन. तो यहाँ पर यू कैन मेक अ केस एंड treat in the subsequent pregnancies if your patient has a viral load of less than 200,000. Ji.
Thank you. Any question from the audience? ये चैट में एक क्वेश्चन है, इन केस ऑफ सरफेस एंटीजन पॉजिटिव prick, but we are fully vaccinated, any test we should get? It's interesting questions. Ji sir.
Yeah. सरफेस एंटीजन पॉजिटिव से अगर प्रिक हुआ है तो या इवन आपको सोर्स का पता ही नहीं है कि पेशेंट डाइड, यू नो, आप रिससिटेट कर रहे थे और उसमें आपको प्रिक हो गया, तो सोर्स अननोन और सरफेस एंटीजन पॉजिटिव, यू शुड इमीडिएटली चेक द जो जिसको प्रिक हुआ है उसका सरफेस एंटीजन LFTs बेसलाइन, और उसके बाद ऑफ कोर्स वो जो धो लें वो सारी चीजें तो करनी है. अगर वैक्सीन, ये तो आपने बेसलाइन टेस्ट कर लिया, अगर विक्टिम जो है वो वैक्सीनेटेड नहीं है तो उसको आपने हेपेटाइटिस बी इम्यून ग्लोबुलिन और 3 डोजेज ऑफ वैक्सीन देने इमीडिएटली, 1 डोज ऑफ वैक्सीन एंड हेपेटाइटिस बी इम्यून ग्लोबुलिन हेज बिग, अगर और 3 डोजेज ऑफ वैक्सीन कंप्लीट करने और उसको फॉलो अप करना. फॉलो अप can be done at 6 to 12 weekly intervals. Surface antigen, LFTs first, if positive, DNA, and so on and so forth. But you have to follow up that person for up to 6 months at least, maybe longer. और इस दौरान उसकी वैक्सीनेशन भी कंप्लीट हो जाएगी अगर नहीं हुई है. हाँ, अगर उसकी वैक्सीनेशन हुई हुई है तो आपने anti-HBs लेवल चेक करना. अगर anti-HBs मोर देन 10 है, यानी प्रोटेक्टिव लेवल से ऊपर है, तो आपने कुछ नहीं करना. अगर लेस देन 10 है तो वही करना है जो नॉन वैक्सीनेटेड स्टेट के साथ किया है. हेपेटाइटिस बी इम्यून ग्लोबुलिन भी देंगे और वैक्सीन के 3 डोजेस दोबारा कंप्लीट करेंगे. थैंक यू.
अस्सलाम वालेकुम. हेलो
जी 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 जी.
सर, इन केस ऑफ दिस टाइप ऑफ प्रेक, मतलब ये कि हम कितने अरसे के बाद प्रेक हुआ, वैक्सीनेटेड है या नॉन वैक्सीनेटेड है, लेकिन आफ्टर हाउ मेनी टाइम हमें ये HBS की तरफ जाना पड़ेगा, मतलब उसका ये या वायरल लोड चेक करना होगा, कितने वीक्स, 4 to 6 वीक्स के बाद प्रेक हुआ और उसके 4 to 6 वीक्स के बाद हम टेस्ट करेंगे?
जी, एक तो ये है कि उसी वक्त इमीडिएटली सरफेस एंटीजन एंड LFTs, हो सकता है वो पहले से ही पॉजिटिव हो, आप डॉक्टर हैं लेकिन आपका पॉजिटिव था, सो यू नो, एक तो इमीडिएट है. और अगर वो नेगेटिव आता है, LFTs नॉर्मल हैं, तो यू हैव टू, और हेपेटाइटिस C को भी चेक करें, HIV को भी चेक करें. अननोन सोर्स है, आपको नहीं पता है कि पेशेंट में क्या था क्या नहीं था, तो आप ये सारे चेक करें. तो ये बेसलाइन टेस्ट हो गए, और उसके बाद एवरी 6 to 12 वीक्स आप चेक करें. आप बहुत कॉन्शियस हैं तो 6 वीक्स पर, लेकिन रिकमेंडेशन यही है कि एवरी 3 months उसको फॉलो करें फॉर एटलीस्ट 6 months, but maybe up to 1 year preferably.
Okay, sir, do you recommend anti-HBs testing after major dental procedures in routine?
Anti-HBs, no.
Or HBs surface antigen, HBs surface antigen in routine after getting any dental procedures?
I ask it in everyone, you know, whether you have headache, epigastric pain, or dental pain, you should have surface antigen at least once in your lifetime as an adult. If you are a high risk person, if you are on hemodialysis, if you are IV drug addict, if you are, other risk factors, I don't want to talk about them now, you need to monitor every year. So yes, it should be checked in everyone.
सर लेकिन इन केस ऑफ वैक्सीनेशन हम वैक्सीनेटेड है लेकिन हमें डेंटल प्रोसीजर्स कराने पड़ जाते हैं 3-4 टाइम्स इन अ ईयर, तो उसके बाद भी हमें ये करवा लेना चाहिए वैक्सीनेशन के बाद भी? डू वी नीड टू हैव दिस टू बी डन?
जनरली नो, बट अगर आपकी
Okay.
वैक्सीन हुई है और आपने सीरो कन्वर्शन डॉक्यूमेंट किया कि आपका एंटी HBs टाइटर प्रोटेक्टिव लेवल पर पहुंच गया, देन यू डोंट नीड टू डू एनीथिंग फॉर द रेस्ट ऑफ योर लाइफ, बिकॉज अगर वो बाद में नीचे भी आ जाएगा टाइटर, ये अगर वो टाइटर नीचे भी आ जाएगा तो एनामेनिस्टिक रिस्पॉन्स इतना स्ट्रांग होगा कि इफ द वायरस एंटर्स योर बॉडी इट विल किल द वायरस. सो हाई रिस्क से हमारी मुराद डिफरेंट है. It's an IV drug addict, homosexuals, multiple sexual partners, sexual workers, hemodialysis patients, etc., etc. वो बड़ी different category है, high risk. Dental treatment उसमें high risk में नहीं आती.
ठीक है सर, वैक्सीनेशन तो हम सब ने कराई लेकिन ये सीरो कन्वर्जन किसी की भी नहीं हुई, इसको इन प्रैक्टिस करना चाहिए आई थिंक.
जी, इसको इन प्रैक्टिस करना चाहिए, और अगर नहीं की है तो एक शॉट लगा के आप खुद देख लें. 6 वीक्स के बाद आपका टाइटर बहुत राइज कर जाएगा तो आपको पता चल जाएगा अब डॉक्यूमेंट हो गई है.
ओके सर, थैंक यू, जज़ाकल्लाह सर.
Any other question?
अस्सलाम वालेकुम सर. ये पेशेंट डिसाइड हमने कर लिया कि ये लाइफ लॉन्ग ट्रीटमेंट है, सपोज सिरोसिस का पेशेंट है, लाइफ लॉन्ग हेपेटाइटिस बी का ट्रीटमेंट देना, ये हमें कैसे पता चलेगा कि हम ट्रीटमेंट जो दे रहे हैं वो कितना इफेक्टिव है? और अगर बाज़ का ऐसा भी केस होता है कि वो इफेक्टिव नहीं भी होता तो हमें वो ट्रीटमेंट देना ही पड़ता है, टीकावीर है या टैफ है, इसके बारे में बताएं.
Right. Treatment or no treatment, you need to follow up your patient every 6 months at least. और उसमें आप वायरल मार्कर्स भी करेंगे, LFTs भी करेंगे, और अगर आपका पेशेंट मेल है और मोर देन 40 या फीमेल है मोर देन 50, तो उसमें आप एवरी 6 मंथ्स HCC स्क्रीनिंग भी शुरू कर देंगे. और अगर सिरोटिक है, चाहे वो 20 ईयर ओल्ड है, तो उसमें अप फ्रंट उसी वक्त आप efficacy of treatment is based on follow-up, clinical and with lab data. Surface antigen positive है लेकिन DNA negative है, ALT normal है, liver normal है, कोई उसमें space occupying lesion नहीं है. अगर मेल है more than 40, उसका alpha feto normal है. So आप चेक कर रहे हैं, आप assumption पे ना जाएं. सिर्फ आप हाथ लगा के पेशेंट को नहीं बता सकते everything is all right, you go home. Come back after 6 months. You have to do certain tests. और यही वायरल टेस्ट जो इम्पोर्टेंट है वो करने हैं.
मेरा मतलब ये है कि ट्रीटमेंट हम दे रहे हैं और फिर भी वो उसका ALT AST कितने अरसे तक वापस नॉर्मल नहीं आता, तो हमें ट्रीटमेंट चेंज करना चाहिए या जो है ना पैग पे जाना चाहिए, ये मेरा मतलब था.
जी, ये ट्रीटमेंट चेंज का तो खैर कॉन्सेप्ट अब आ रहा है कि अगर वायरल लोड 2 साल के बाद लेस देन 2000 है, चाहे वो 1500 है, चाहे 1600 है, और ALT सब ऑप्टिमल है, रिस्पॉन्स नहीं हुआ, तो चाइनीज ने एक बहुत बड़ी स्टडी की थी जिसको एवरेस्ट स्टडी कहते हैं. वहां पे पेग इंटरफ्रॉन ऐड किया था इन पेशेंट्स में अगर उसको डीकम्पनसेटेड सिरोसिस नहीं है, और इंड्यूस किया था बेटर रिस्पॉन्स रेट. सो ये चाइनीज गाइडलाइन में आ गया है कि आप इन पर्टिकुलर पेशेंट्स में आफ्टर 2 years अगर उनका रिस्पॉन्स नहीं है तो आप नॉन सिरोटिक पेशेंट्स में पेगाइलेटेड इंटरफ्रॉन ऐड कर दें न्यूक्स को बंद करें या कंटिन्यू करें, इट इज अप टू यू, लेकिन पैगाइलेटेड इंटरफ्रॉन इंट्रोड्यूस करें फॉर 1 year एटलीस्ट जी. So 2 years is the answer.
Thank you, sir.
इसमें एक आखिरी क्वेश्चन गालबन चैट में बूस्टर डोज से रिलेटेड है. आफ्टर 5 years in healthcare providers.
No, हर एक में अगर आपका सीरो कन्वर्शन डॉक्यूमेंटेड है तो देयर इज नो नीड. अगर आपकी सीरो कन्वर्शन डॉक्यूमेंटेड नहीं है तो मैं रेकमेंड करता हूँ, या किसी गाइडलाइन में तो नहीं है, कि आप एक शॉट लें और अपनी एंटीबॉडी लेवल 6 वीक्स के बाद चेक करें. अगर वो हाई लेवल पर चली गई हैं, प्रोटेक्टिव लेवल्स पर है, तो आप ऑफ कोर्स आपका रिस्पांस है, एनामिनिस्टिक रिस्पांस था, आपको ज़रूरत नहीं है. हाई रिस्क से, जैसे मैंने कहा, हम हेल्थ केयर वर्कर्स को कंसिडर नहीं करते. हम हीमोडायलिसिस, आईवी ड्रग एडिक्ट्स, होमोसेक्सुअल्स और एक्सेट्रा एक्सेट्रा उनको कंसिडर करते. So healthcare workers में it is important to document anti-HBs level 6 weeks to 12 weeks after completing a course of vaccination. Thank you.
Thank you, sir. It's about time. Thank you very much, Dr. Altaf, for this session, and we learned a lot from. And inshallah, we'll continue this program. Next, Kiran, over to you, please.
Sure. Thank you very much, Dr. Altaf. Next week's session हमारा है acute HBV infection, HCV co-infection by Professor Shahid Sarwar. We do encourage cases from the participants and would like them to present their own cases. I think हमारे कुछ participants हैं जो कि अगले week में इंशाल्लाह they will present their own case. And we are grateful and thankful to Pakistan Society of Hepatology and Ferosson's Laboratories Private Limited for the unrestricted educational grant, and our team at PARSA Trust in PARSA ECHO Pakistan. So Allah Hafiz. Uzair, you can call off the meeting. Thank you
Sure,
very
ma'am.
much.
Allah Hafiz. Everybody, good night.